Okay, thank you. So, what did we know about premenopausal hormone-responsive early breast cancer before the results of the SOFT and TEXT, who changed the practice in this population of women? So we know that tamoxifen alone for 5 or 10 years was recommended in premenopausal women. The value of ovarian function suppression or ablation for women receiving tamoxifen as part of their treatment was unknown. We knew that women developing chemotherapy-induced amenorrhea had a reduced risk of relapse, and that the likelihood of chemotherapy-induced amenorrhea correlates with older age and is really rare in women less than 35. And we had no data on aromatase inhibitors in premenopausal women. You all know the design of the SOFT and TEXT trial. The TEXT is comparing tamoxifen and exemestane in the presence of ovarian function suppression, and SOFT randomized between tamoxifen plus OFS, and exemestane plus OFS. I would like to draw your attention on the fact that the two populations were different as regards the chemotherapy. So in TEXT, 60% of patients received chemotherapy. In SOFT, 53% of them received chemotherapy, but the main difference was that in TEXT, chemotherapy was given together with ovarian function suppression, whereas in SOFT, women finished their chemotherapy and were randomized if they resumed menses after chemotherapy. So this is a major difference in the population of patients. So which are the updated results of SOFT in terms of disease-free survival at 8 years median follow-up? You can see that escalating endocrine therapy from tamoxifen to exemestane plus OFS was associated with a 7% reduction, improvement in disease-free survival, and this is once again an absolute benefit. We decided to focus in all the publications on absolute benefit and not relative benefit. Then the pre-planned secondary endpoints of SOFT were distant recurrence-free interval, and you can see once again then escalating endocrine therapy is associated with almost 3% improvement in distant recurrence-free interval, which is an important endpoint, and we started to see a small improvement in overall survival. So you go in the distant recurrence-free interval from 88% to 91%. But in the pre-planned subgroup analysis, we divided women who did not receive chemotherapy, and chemotherapy decision was based on the physician choice, and in patients who did not receive chemo. And in the subgroup of patients who did not receive chemo, and so in patients at lower risk of recurrence, you can see that tamoxifen alone is a real very good option, and that the outcome in both distant recurrence and overall survival is really very good. And this is, I think, it's a very important message, because in the past, many premenopausal women received chemotherapy just because they were premenopausal, and they were considered to be at higher risk of relapse. So tamoxifen in low-risk patients is for 5 years, is a very good drug, and you have 97.8% of women without distant recurrence at 8 years. In the prior chemo population, things are different, and the distant recurrence-free interval is significantly impacted by escalating endocrine therapy, and you have a 4.5 absolute improvement by giving exemestane plus OFS. And here, the overall benefit in overall survival starts to get more significant. What about TEXT? At 9 years median follow-up, we had a sustained 4% improvement in disease-free survival, which was evident in all the subgroup of population, so women who received chemo, women who did not receive chemo. And we had a 4% absolute improvement in breast cancer-free interval, and a 2.1 absolute improvement in distant recurrence-free interval. Unfortunately, or maybe fortunately, we did not see also, at 9 years median follow-up, an overall survival benefit. But you can see here that women are doing very well with both treatments. And this is true for all treatment subgroups. Of course, if you escalate treatment, you are faced with higher adverse events. And you can see that, apart from the very well-known side effects of tamoxifen, that if you give ovarian function suppression, you have a higher proportion of hot flashes, but what is more important, sexual problems. And you have, of course, with the aromatase inhibitors, an increase in joint pain and osteoporosis. So you need to know what kind of side effects your women will be faced with. Let's move to very young women. These are the latest soft results, and you can see that in breast cancer-free interval, these women are the ones who most benefit from escalating to tamoxifen, from tamoxifen to exemestane plus OFS. And you go from 65% to 80%. And this is also true in distant recurrence-free interval, from 74% to 82.4%. Of course, and these are the data on the 2017 publication in the less than 35 years women on the quality of life. You have, of course, more vasomotor, more gynecological, more musculoskeletal symptoms if you increase your treatment, but you can see that, and we all know that women are resilient, and the side effects by increasing treatment are disappearing or are less evident at 60 months, so at the end of treatment, and they are higher during the first 2 years. So women learn how to cope with these side effects. We are going to publish now sexual problems, so to focus on sexual problems in softened text, and you can see that lots of the specific sexual problems are higher, and the higher curves are the ones with OFS in presence or chemo or not, and the lower are the ones with tamoxifen alone, also in the presence of chemotherapy. And there are specific age differences, and you can see that the younger women, the black curve, are the ones, the less than 35, are the ones who suffer most. These are the 2 years data. But this publication will be important because not only vaginal dryness, but also sleep disturbance, bone and joint pain can predict sexual problems during the first 2 years. So the early identification of these symptoms and their, of course, timely intervention can improve these important aspects of women's life in the presence of adjuvant therapy. What about timing of OFS? I was particularly interested because of some results of the 5 years data of softened text about the initiation of OFS. We know from very old data that tamoxifen with chemotherapy is not a good idea, so we postponed the use of tamoxifen after the end of chemo. And in softened text, as I mentioned before, OFS was given together with chemo in text and after chemo in soft. And many investigators at the beginning, when we were discussing and designing these trials, were worried about giving OFS together with chemo. So we looked, Meredith Regan, who is the statisticians of softened text, with a very complicated statistical design, looked at the different population in softened text, so women who received chemo. And you can see here that breast cancer-free interval and distant recurrence-free interval is exactly the same in women in the blue curve who received chemo with OFS, and in women, as in soft, who received chemo, OFS after chemo. And this is also true in the less than 40 years women, who are the ones who are less likely to develop a chemotherapy-induced amenorrhea. And those results have been recently confirmed in a different setting by Matteo Lambertini, who did the meta-analysis of LHRH to protect against fertility problems in women who receive chemotherapy. And you can see that their safety data in ER-positive women looks exactly the same as ours. So the disease-free survival and overall survival is exactly the same in women who receive GnHRH to prevent fertility problems and the ones who did not, so received chemotherapy alone. So these data indirectly confirm our observation. What about duration of OFS? We do not have any data about extended duration of OFS, and Partridge tried to do a pilot study in women who received 5 years of OFS to extend treatment by 2 additional years, and in 3 years they enrolled 36 patients, which means that women who do not want to go beyond 5 years with OFS. So we have only the comparison with shorter duration with the Austrian trial, which gave tamoxifen or anastrozole in the presence of goserelin for 3 years. And you know the data at 10 years median follow-up, these women do very well, no difference between tamoxifen and anastrozole in the presence of short-term OFS. And you can see once again that these women have a very good outcome. But what are the differences between softened text and the Austrian trial? The Austrian trial in the Austrian trial were randomized women at lower risk of relapse, so they were more lymph node negative. There were more smaller tumor, and the most important information is that only a minority of these women received adjuvant chemotherapy, which means that they were at lower risk of relapse. And so, of course, we cannot do cross-trial comparison, but we can infer by this data that in a lower risk population, maybe you can de-escalate treatment, and 3 years of treatment could be as good as 5 years. Whereas in a higher risk population, you may be and you should probably go for 5 years. I just want to mention before I finish that 2 years ago we published online on GCO a very, I think, useful paper looking at the impact of different treatment escalation in softened text according to different clinical scenarios. And I encourage you to read, because in this paper you can find from a practical point of view the kind of population of women according to age, all the clinical pathological features, who are more likely to benefit from de-escalating or escalating. And an application is in the process of being released, where you can put the details, a little bit like Adjuvant Online. You can put the details of your patients and you can estimate the benefit with the different treatment options. And just a word of caution if you give ovarian function suppression, especially if you give an aromatase inhibitor, you need, and this is stated in all the guidelines, BCY, ASCO guidelines, ESMO guidelines, and St. Gallen guidelines, you need to check for the estradiol levels. This is the soft est latest results, and you can see that in SI has 17% of patients, you have estradiol levels who are above the threshold of suppression. And so this is really important to know, and you need to check, even if the assays are not very perfect, but you need to check your levels. So in conclusion, the recent results of soft and text after 8 and 9 years of median follow-up confirm the efficacy of escalating endocrine therapy in women at intermediate and high risk of relapse and de-escalate in low-risk women. So OFS should be discussed with all premenopausal women at intermediate and high risk of relapse, and the very young women, unfortunately for the burden of side effects, are those who more benefit from OFS, even if they received, and almost all the patients less than 35 years in soft and text received chemotherapy. The aromatase inhibitors provide additional benefit over tamoxifen, and the degree, I didn't have the time to show you the data, but the degree of benefit in different clinical scenarios can be estimated. OFS duration is still an open question. We have some hints to try to sort out which is the best duration. The ovarian suppression needs to be regularly checked. And of course, as it was mentioned before, adherence and compliance is a very important issue, and adherence and compliance are very low in young women, and they are associated with worse outcomes. So the treatment burden, side effects, and quality of life need to be addressed and need to be checked. And the timing of OFS with chemotherapy can be discussed on an individual basis, and I would suggest that in women who are less than 14 and will not develop chemotherapy-induced amenorrhea, these are the women where you should start together. In a 45-year-old woman who most likely will develop a chemotherapy-induced amenorrhea, you can wait until she eventually resumes menses to start OFS. And I thank you for your attention.